let's talk about what we're learning today. You know, our communication is such a vital component to feeling connected with people. Without it, you know, in some form or fashion, whether it's communication through speech or communication through a device or gestures or anything else, you know, isolation and potential mental health challenges can be inevitable for individuals with living with brain injury. You know, difficulty with communication can also create a really significant struggle for those serving or surrounding people with brain injury, whether they're caregivers, families, providers, anything, leading to feeling hopeless or ineffective. That's why I'm really glad to have Dr. Katrina Miller here with us today to talk about communication and brain injury. A little information about her. She's the owner of K.E. Miller Enterprises, which is a communication empowerment company. She has over 25 years of experience in the communications disorders profession and has presented nationally and internationally. Dr. Miller is currently the director of the Division of Communication Sciences and Disorders at Shenandoah University in Leesburg, Virginia. Prior to her current position, she created a neurogenic aphasia group in which Durham, North Carolina residents who had a neurogenic event were able to participate in group and individual therapy sessions to expand and improve their communication skills. She particularly enjoys mentoring students and early career professionals. I'll be sure to put her website and her email in the chat. I'll do that right now. All righty. And so then I'm going to pause my share and transition over to her slides. And while I'm doing that, I'll turn it over to you, Dr. Miller. Thank you so much for being here.
And thank you so much, Lauren, and for the Brain Injury Association of North Carolina for the wonderful invitation. I was a big part of the education committee a number of years ago, so I was excited to be able to come full circle and to be able to present what I deem is a little bit of knowledge, hopefully that'll be helpful to not only professionals, but to family members and you who have been involved or had a traumatic brain injury. All right, so let's get going. You can flip the PowerPoint, Lauren. We are ready to roll. We talked a little bit about the objectives. My hope is that when you finish our time together today, that you'll be able to identify some of the cognitive deficits that are associated with the brain injury, also to identify some communication deficits, and we'll talk a little bit about the difference between the two. List some intervention activities that'll be useful, beneficial for a person with a mild to moderate brain injury, and also be able to identify some strategies that will be useful for the brain injury population. One of the things that I like to think about communication is that it's empowerment. You have probably heard the term before, finding my voice, or I lost my voice, and it can refer to a lot of different things, maybe in terms of the way you felt about something and then you were able to voice that opinion, or how you weren't able to do those things that you wanted to do, and you finally found the strength or courage maybe to do those things or to leave a situation that wasn't the best for you. I like to think about what I do as empowering not only my patients and clients, but also my students and the persons that I teach and train, because communication is so important. It transcends and expresses who we are as individuals and as groups. So I like to think about empowering people and empowering it by being a communication empowerment. So that's kind of how I look at what we do as professionals, being able to empower not only our clients or our consumers, but also our colleagues and the persons that we're come in contact with. So think about and keep that in mind, that communication is a way to empower you, because it's such a strong component of what we are and how we are as human beings. So we're going to start with some terminology, and please excuse me if you're already familiar with these. I just thought it would be a good kind of, I can use the term, jumping off point for us. I'm sure you've heard the term acquired brain injury, and this refers to any type of damage to the brain that has occurred after birth. And so it can be even throughout any time in one's life, and it's different from a congenital deficit. It also is important to think about it may encompass other degenerative diseases like Parkinson's, but not considered an acquired brain injury, although you may see some of the same deficits across disabilities. Aphasia is a term you may have seen or read in the literature, and it refers to language disorders that are caused by neurological events. And all the syndromes of aphasia have an expressive component. So a person with an acquired brain injury may also have a language disorder or a language component as part of the neurological event. The term cognitive linguistic, it refers to the merging of language and cognitive skills. So you may see the term cognitive linguistic deficits, meaning that there are cognitive and language deficits that a person is demonstrating. And it's also more of a precise science that scientists and aphasiologists and persons who specialize in brain injury have look or merging the skills of a person together, or looking at the skills not as separate components, but as components that work together. Cognitive or cognitive deficits are, the term refers to anything that's related to intellectual ability. That includes your thinking, your reasoning, and your memory. Pragmatics are how we use language, and that includes things like personal space, intonation, humor, and it's a very, very important when you look at pragmatics, when you look at even from a cultural standpoint, because pragmatics are often those things that are misinterpreted because they tend to be nonverbal and a lot of times, and it's a different way or component to use language. Terminology continued. Of course, a traumatic brain injury is brain damage that has occurred as external force. So something externally, a hit or fall, has caused the injury to the brain. Social cognition refers to ability to understand social cues and being able to respond appropriately in situations. Social communication is a set of verbal and nonverbal skills that allows for, excuse the typo there, adequate communication. So if you see the term social communication skills, you have a better idea of what that means. Social competence basically is the ability to achieve those personal goals through social interactions. So these are all part of communication, and just thought it'd be important to kind of talk a little bit about the terminology. And of course, social skills are cognitive and interpersonal ability that's used to engage in appropriate social behavior and positive interprofessional encounters. And this is an area that a lot of industries and businesses are now looking for persons that are able to maneuver this social skills component. And a lot of things there are a lot of reasons why I think there's some disconnect with that now. But if you are in the business industry, you see that there are a lot of social emotional learning or that terminology that may be incorporated in a lot of their business manuals, and a lot of managers work with that area are always looking for persons to help with social skills training with their new employees. Okay. So I thought it would be important at this point to talk a little bit about aphasia, because often in traumatic brain injury, the deficits overlap. And I wanted to make sure that it was a thing where you understood. And since we have such a mixed audience with professionals and also caregivers and persons who've had injuries, I wanted to make sure that we fully understood the difference, yet the similarities between the two. And aphasia is an acquired language disorder that results from damage to the brain in areas seen in people who are previously capable or previously had language or were using language appropriately. And it's important to remember that there used to be a belief in terms of childhood aphasia, which is something that can occur, but it always is after the fact. A person that has had language and use language appropriately, and then something happened that they had a language disorder. And remember that developmental language disabilities incurred individuals whose ability to use language was never obtained. So when you see the definition of the word aphasia, it's a cue that the person did have language previously, but now they have had some interruption of that use of language. Okay. Some of the characteristics that you may see of a person who has aphasia, some of the most common ones include anomia. And of course, that's the ability to name objects, people, pictures, events, experiences. Anomia, or the inability to do those things. You might see some language fluency, and that means not being able to put sentences and complete thoughts together. So that would be something that would be difficult for a person who demonstrates aphasia. Conversational speech may be difficult. You may have auditory comprehension where they're hearing appropriately, but they're not comprehending what they're hearing. They're not able to do the decoding aspect of it. Ability to form speech sounds may be have difficulty with that. Ability to repeat what has just been said, so have difficulty doing that. And of course, there may be deficits in reading and writing. So these are some of the processes that are most affected by a person who has aphasia. And you, because I already guessed, there also are some of the deficits of the person that has a brain injury also. So some of these skills overlap, and it's important to remember that as you're treating and addressing some of the deficits. Some of the other characteristics you might see, and again, these are evident in persons that also have brain injury. There may be a element of fatigue, just not able to continually do the things they used to do, and may find that they need to rest more. So seizures may be a characteristic that's also associated with a person that has aphasia. And visual field disturbances. And when we say that, that means a lot of different things. Being able to interpret what is being seen, maybe having some inability to see a full picture. Maybe part of the right field is cut off, or more likely it's the right field, but not really being able to interpret what is being seen. Blurry vision can come under some of the field, visual field difficulties, and the perception, just how far depth perception is. So the person may have difficulty when it comes to moving in space, sitting down, and not so much that they're physically unable to do that, but the perceptions are different, are off a little bit because of the field disturbances. The next one is perseverations, continually repeating what is being said or repeating the word after the speaker, kind of being stuck on that one word is perseverations. Abstract concrete imbalance in terms of understanding what word meanings are and being able to differentiate between them. There may be some deficits in that. Catastrophic reactions. Everything is just, the smallest things are disastrous. So you drop a glass and it's kind of feeling like it's the end of the world, but the reaction to maybe everyday mishaps are a little distorted or inappropriate. And despondency, which kind of comes with the feeling of depression and can also overlap with those who have had brain injuries also. One thing that you probably see a lot of, especially professionals, is the term executive functioning. So it's important to know that executive functioning is attached to the frontal lobe, and it serves as connections to other sections of the brain and are fundamental to executive functioning in terms of where it works. The frontal lobe also coordinates input from other portions of the brain, organizes and regulates behavior. And the frontal lobes are fundamental to anticipation, goal selection, planning, self-monitoring, use of feedback, and complete or purposeful activities. So just understanding what the frontal lobe does you can fully understand how damage to that may occur. Often, the frontal lobe is, not often, it is one of the larger lobes, and it's located in the front of the brain, obviously, frontal. And one thing that's unique about the frontal lobe is that it's not fully developed until we're about 25. So just think about the persons who have the highest population in terms of brain injury and in terms of damaging that area of the brain that's not already developed through an accident or injury, how those issues of executive functioning are further exacerbated because the frontal lobe wasn't fully developed and then it's damaged on top of that. So as professionals, keep that in mind when you're planning and thinking about your sessions and what to do with your clients. So Lauren, I was just thinking, do we have any questions? Is this a good time to stop? You good?
No, yep, all good.
Okay. All right. So when you're thinking about executive functioning in areas that may be impaired, things you can work on or look at, you're thinking or you're looking at time management. So that includes time estimations, scheduling, completing of scheduled activities, and alteration. Attention, that includes focused attention, sustained attention, selective, altering, and divided. Planning, organizing, and sequencing. Memory, that includes repetition, visualization, association, grouping, writing it down in terms of all the things we do for each of these areas. I also like to think of executive functioning as what we do every day. Probably all of us use some level of executive function to get to 12 o'clock today. You, of course, had to figure out what you were going to wear if you didn't do that the night before. Make sure that you arrived at wherever it is now that you are. So there was some time management. And in terms of getting to the place on time, there were steps you had to take to get there. So you had to make sure that you drove or your transportation was completed in a timely manner, or even moving to a different room in your house so that you could have your computer up at 12 o'clock. These are all things that include executive functioning because there was an element of planning that went into it. Often with executive function, we do it so automatically we don't realize the steps that are needed to get through this executive functioning process. And so often it's something to remember when you're working or caring for a person that's had a brain injury, that they may actually need those steps broken down. So we do it so automatically, we're planning, organizing, sequencing, that we forget that, okay, I might need to help break this down at this level, remind them of this, and do this. And we've also incorporated strategies as individuals as to what helps. Writing things down. Probably most of us have used a date book. I have one that's about this big to keep track of all the things that I can't remember or to help me with my memory. And I often, if I'm real organized, can actually group it. If there are things that I'm doing with church, that's one color, work related, it's another color, personal, it's another color, little anal, but those are different ways or different things we use to help with the memory, the visualization, and the organizing. Everybody has a different system. I know there's some people that use Post-it notes, but these are all part of executive functioning and ways to help us with the organization and planning that we have in place, and can also be translated to help persons who have brain injury to help with the executive functioning. And we'll do an activity I think I've included in the slides later to help a little bit with that. Also remember that disorders of executive functioning can also be characterized by, so we talked about what executive functioning is and what a person who's had damage to that area may experience. So of course there would be some difficulty with the planning and organization. And we just mentioned how Mentally, we do a lot of that organizing. And if you find that there are disturbances in the executive function, that you might have to actually teach that or write those things down. A person that may have disorders with executive functioning includes trouble identifying what needs to be done, where to start. And if you've ever had a lot of things to do, you've kind of felt that way. Okay, where do I start? And you actually might have to take a minute to sit down and say, okay, what's the most pressing needs? But believe it or not, that's a process that we go through with executive functioning that may not be as easy to do if a person has had an injury to that area of their brain. They'll have difficulty sequencing what should go first, what should go second. Difficulty carrying out the steps. You may know what needs to be done, but you have difficulty completing that task. Difficulty beginning the task. We often might call that procrastination, but a person has had some difficulty or some injury to that area, maybe something that's consistent in terms of beginning tasks. You might want to start with that is, okay, you have 2 minutes before you need to start, or you might even need to cue it a little bit further. Let's pick up our pen and start the task, or whatever the task is you need the person to do. It's a lot of different ways that you can set up the schedule or help persons with these areas that they may be having difficulty with. Problems maintaining attention. We've all, I'm sure, have been there where we're having difficulty focusing. And some of the things would be a quieter environment may work. Not trying to multitask, doing one thing at a time. Trouble evaluating progress on the task. How far have I gotten with this task? How far should I be with this task? So a person that has disorders with executive function may have some difficulty in that area. And difficulty taking feedback or suggestions. You need to work a little faster, or let's do this first. Just being able to process even the feedback or the suggestions that are given to them may be difficult. All right, so good, we're a good time. We'll now talk a little bit about some of the interventions. We talked kind of briefly about what some of the disabilities are you may see, some of the disorders. And as I'm sure all of you know, any of these topics can be a whole course, can be a whole section all day to discussion. So we're just trying to get a quick kind of overview of things. So when you're talking about intervention, and this is also important for those of you who provide not only care, but caregivers, that the purpose of intervention or therapy, or treatment, you might hear the words interchanged, is that you want to design it to improve your patient's or your client's current communication strength. So you're taking the strengths that are already present and you're building on those. It's very important when you're looking at treatment is that you have realistic expectations and goals, especially if they're time oriented. So if you have a month of treatment, or you want to get a skill in a month, it's important that you're setting realistic goals with your persons. And even personally, when you think of something that you're trying to do, you want to make sure that that expectation is realistic. As we all may have dealt with being on a diet. Oh, I want to lose 10 pounds by next Friday. Realistically, those goals need to be set so that they can be achieved. And that's what you want to keep in mind, not only as a professional, but also as a family member or a caregiver or a person that has had an injury, to set some realistic goals for yourself. You should have family and caregiver input. It's very important as professionals that we listen to our families and listen to our caregivers about things that are the most important for them and how to plan our intervention. Should have your patient input. Sometimes it's important for the family, but what's important also for your patient. So you want to have a complete buy-in, if I can use that terminology, for your patients, your clients, your family members. Everybody should be involved in setting the therapy goals and the treatment. Often our treatment and intervention, unfortunately, are influenced by insurance. sometimes by the patient and sometimes by the family. And I say this because often you may have a patient that has had numerous therapy and interventions and they're just tired. So your plan may be influenced by that. Family members may need to return to work. They're not always able or available to transport patients to the facility. So these are all things that as providers we take into account, and also that affect family members and of course the person that's had the brain injury. So you always want to consider these as factors, whether positive or negative, when you're planning your intervention and your treatments. One thing that I also wanted to mention that may be overlooked is the cultural component that needs to be considered when you're looking at treatments, when you're looking at your diagnostics, when you're planning your goals. And I just wanted to talk briefly about some variables to consider as professionals. And also, I thought it would be important to mention these at this time because as family and caregivers, they become such an intricate part of who we are as humans that we forget that they're different things that occur in our surroundings, in our circle, in our culture. And you may, as a caregiver or a patient, need to be an advocate for yourself and share some of these variables or some of the things that are a little different in terms of culturally important to you with your caregivers who may not always be aware of that. It also helps with your intervention planning. So as far as some cultural variables, and we're just going to talk about a few of them, individualism and collectivism, and that speaks to what cultures or individuals or societies placing freedom of the individual, collectivism more important the needs of the entire group versus the individual. So individualism may be seen in more European countries and cultures, and collectivism more in Arab, African, Asian, and Hispanic cultures. And a way to summarize this is the care or the disability is seen more as a collective concern with collective goals versus an individual goal. And this is real important when you're thinking of long-term therapy goals and even the initial who comes to your therapy sessions. You may see more of a collective collaborative approach where there's several persons that may come to treatment versus an individual approach where the individual comes. Just be aware of that as caregivers and as persons too to advocate for care. Another variable, nonverbal and verbal communication styles. And this refers to nonverbal and verbal communication styles in terms of language and communication styles that are closely correlated to race, ethnicity, and culture. Nonverbal communication can include the communication distance, how far you stand from each other when you're talking, body language, eye contact, silence or loudness, inflections, and stress. These are all part of nonverbal communication that are very highly, related or correlated to race, culture, and ethnicity. And verbal communication styles, which includes pragmatics, the way that language is used in terms of greetings, how close physically you get to persons when you're talking to them. In non-Western cultures, we have more of a vertical communication pattern, which flows from those in higher prestige to those in lower prestige. So in terms of the communication style of, for example, a teacher and a student communication. And in Western cultures, there's more of a horizontal, it's seen more as an equal. And this is something that I saw a lot when I worked with, did some of my travel abroad with Asian cultures in terms of the high respect for teachers, so that students often won't ask you questions if they're not understanding because of that power or that nonverbal, that power dynamic in terms of the communication from a higher to a from a higher prestige to a lower prestige status, if it's making sense. And I'm sure we've all been in, maybe you haven't, or you have been in situations where the body distance is different. There's some cultures where the distance is closer, and you may feel in Western cultures, ours is about 12 inches difference. In other cultures, it's a little bit closer. That in some Arab countries, it's closer. And so that's things important to remember also when you're participating in your evaluations, in your treatments, and also, like again, as family members, to remember to advocate for those things that are important in terms of something as simple as communication and understanding the differences. Another variable is the power distance variable, which is considered a social relationship between people of different statuses. So this can also include the relationships with men and women. Sometimes the power distance variable is impacted. The high power distance cultures usually don't question superiors, and that was what I was making reference to in some of the courses that I taught in China. Students wouldn't ask questions because of that power distance dynamic. And lower power distance cultures, they don't necessarily accept everything that a superior says, but they understand that in that culture, there is a difference in terms of the power and the distance variables. Hope I'm making sense in terms of these explanations. And one that I find very important variable that I wanted to also mention was the time orientation. And basically it's just how important time is, and it differs across cultures. So when there's a culture that's long-term and future-oriented, the establishment of the long-term goals and the priorities are highly valued. So it's real important to say, in 4 weeks, we're going to have this goal, or in 8 weeks, we're going to achieve this. Where in their cultures that are more focused on the past, the establishment of short-term goals are more obtainable, and the preserving the present is more important. So in Western cultures, we are more oriented toward the future, versus in non-Western cultures are more focused on the past. So this is often something to think about when you're setting your goals. We see that you should, want to work on this, want to achieve this. And often you may have cultures that it's okay. We're here to support the person with a disability. And it's just not as important that we get there in a timely manner, but we will get there, continually working on that skill, if I can make sense in terms of that. So talk a little bit about how or ways in which you might have intervention or create intervention. I strongly support group intervention. We communicate for the most part in groups, and I feel that those are the most beneficial and appropriate ways to attach cognitive linguistic disorders. There are a variety of social groups, and these are groups that are come to mind and are groups that were in North Carolina. Lauren mentioned the neurogenic aphasia group that worked with at one of the universities there. And you may be familiar with the triangle aphasia program. And although it's geared specifically for persons who have aphasia, these programs are group interventions, and they help persons with communication. You may also want to be a part or create a part of a singing group. Music therapy is a great approach for persons who've had brain injuries. There are a lot of different ways to approach this. There are Parkinson's singing groups where they specifically work with persons who've had Parkinson's. There are group dynamics where persons just get together who've had injuries, brain injuries, and they just sing. It can be like a sing-along, no particular goal but to enjoy singing and enjoying being together. And they're reading groups. I've had opportunities where groups of persons who had brain injuries, have read books together. They've chosen a book and they read it together as a group. And they've also may have been responsible for reading X number of pages before they met again. And then they would talk about the book and share their thoughts about it, which incorporated lots of different skills, but it's also a way to open up social circles. And one of the things that I noticed in the groups that I've led is that persons often create individual friendships in the groups, which often led to other group interventions or other group settings, which all helped to stimulate the communication. And it goes back to what I talked about earlier, being empowered, always having the ability to communicate. So some of those groups included community integration. You might have heard that terminology, where they're outings that incorporate all of the skills that your patient or clients have worked with, your family member has worked on. They may include an outing to a restaurant, which would help with mobility, moving, the transportation. If there is a situation where they have to transport themselves, can they ride the public transportation? Can they secure a ride? So there are lots of different stages, but doing this group intervention or this group interaction allows a person to maneuver through those situations and those settings, and therefore empowering them with their communication skills. I think I have another one. Little history of group intervention. It dates back to World War II. There were studies that showed the group treatment affected communication. We kind of know that the group interaction does that. And during the 80s and the 90s, there were more group treatments were occurring. And it shifts the primary focus to more of everyday integrating activities, how we live. One thing that I think occurred is that after World War II was such a large number of persons that had these injuries that they saw it as a better or quicker way to do treatment. But I feel that group interaction is very, very effective in helping persons with brain injuries to integrate themselves back into the things they like, their communities, their societies, the things that are important for them. Continuing type of group intervention, we talked a little bit about communication groups, and that may be where the therapy is direct or indirect. So you may actually have activities or drills that you're doing as a group, and a group can be two people, and you're working on them together. They can be social groups, psychosocial. We talked a little bit about that. I have feeding groups in here, and that's something that is usually seen at an acute hospital level, where persons may be having trouble with eating or swallowing, and they're seen together in a group with several professionals. That's of course beneficial and often supported by insurance. And then support groups. There are stroke support groups, brain injury support groups, and of course family counseling. And these are all types of group intervention that can be utilized for persons with brain injury and are of course including those with aphasia. You may or may not have seen the life participation approach to aphasia. And again, I use aphasia, but these are also components that are important or can be used for brain injury. And one thing that the life participation approach does, it's a intervention strategy that basically integrates the person back into those things that they enjoy. The strong component is that it utilizes persons in the community to help support this person getting back to things they enjoy. It enhances exactly what it says, being able to participate in those things that are important in life, where they are being a member of a choir, maybe attending social organization that you enjoy, sorority meetings or community meetings. These are ways that persons in those organizations or components of that can help a person to get back to doing those things that they enjoyed. It is often measured, it's been measured that it's very successful, and it takes a minimum amount of training or direction to help persons to integrate their friend, loved one back into those things that they enjoy doing. So it's a tested and proven way. You might see it in some of the literature that talks about ways to incorporate persons back into things that they enjoyed in their communities. Just a little bit of research and group intervention. As a researcher, aphasia groups have been proven that persons with aphasia are in a community that can accept and nurture them. It provides a new outlook on life, especially for living successfully with aphasia. Group reminiscent intervention reduces depression in older adults. And what reminiscent therapy is, it's called a therapy, but it's a really good approach, and it just helps persons with reminiscing. For example, one thing that I've seen with reminiscent therapy is when you're with a group of persons, you help to stimulate conversation, and you may do something as simple as tell us about your first high school football game, or your first kiss, or your first date with your significant other. So these are things that have happened to most persons, and it allows them to pull on memories and things that are in the past, but it also gives a great catalyst or way to start communication. And there are specific techniques and ways you can utilize this strategy or this form of therapy in therapy sessions. And it's the same thing you can do as caregivers or persons that are supporting others with brain injury to help with the communication. And group intervention, of course, provides a social context for your acute aphasia. Um, Please do not exclude. Yes, yes. Auditory processing disorders, aphasia. Yes, yes. All of those kind of things overlap. So someone was saying don't exclude those. The processing part is very important. It comes with the aphasia and also with the processing of the brain injury. Yes. I think I had as the next one, Lauren, again, the fundamentals of group. It's very important that when you are working with your groups that you specify the purpose of your group. So if your group is strictly to be social, then that's the purpose of the group. If your group is reading, so you want to make sure persons understand that we're going to do some reading. If it's to I think there was reading group, singing group, we're going to sing. So make sure the purpose of your group is specified and everyone understands that. Must be provided an opportunity to communicate with peers. Definitely, that's one of the best parts of a group when you have really, really good support. I found that it really works if you have persons that are fluent and some that struggle a little bit, but it helps with the dynamics of your group because they really help each other and support each other in ways that are just unbelievable to watch. Teach whatever communication strategies you want your persons to learn. And again, I'm speaking to the caregivers and to the professionals. Practice those communication strategies together. Observe the successful strategies that are used by others. And any of the psychosocial benefits are already mentioned. Just that feeling of belonging, also being able to help and to support each other. I've seen it countless times occur with across the lifespan, young adults. I've seen it supported in older adults, that it's kind of a camaraderie that works together in groups that's a little different than individual therapy treatments. And why do they work? I just said that they provide a chance to practice the communication. Peers are very tough, but really supportive and help each other. It stimulates real communication, and it's very fulfilling. Persons feel like they're part of a community, which is always important. And it also helps to practice those skills that they may have learned individually or independent of the group dynamics. So functional skills, I thought it might be kind of, if I could use the word fun, to think about ways you can introduce this as professionals, as caregivers, if there are ways you want to help your loved one who may have had a brain injury. This is a functional skills task. So I'll read through it and we'll talk a little bit about how you can utilize this in your practice and how it can be helpful with your loved one. You have a busy day ahead. You have a doctor's appointment. You must also go to the party store to buy decorations for a party. fill up the car with gas, go to the post office to mail a package, and go to the bank to get enough money to pay the doctor's fee. He demands cash on visits. You must order and pick up a special ice cream cake for a relative's birthday, bring your prescription to the drugstore, and meet a friend for lunch. The post office, bakery, drugstore, and party store all close at 5 p.m. and the bank closes at 3. It is now 10. Your doctor's appointment's at 2. At what time should you leave the house? Where will you go first, second, third, etc.? For the most part, this is something we do all the time, every day. We're looking at our schedules, but this is an activity that you can utilize in your therapy sessions as a caregiver and help your family member to organize and plan and use all those executive functions. So I often have used this, and I'll start with, okay, what do we need to do? And we can highlight that, the things that need to be done. You also want to look at the time. So you can set up the time schedule, what has to be done by this time. Another thing I like to cue persons is what's close by. And we can kind of play a little bit with that because they all close, they're things that close at a certain time. And these are just the ways we plan our schedule, especially with the gas. Now, a lot of times we have said, and I've said this often, you can't do anything until you get to the bank. You need the money first. So you might have to go to the bank first. And then if depending on where your gas tank is, if you're on E, you're not gonna be able to go anywhere until you get the money, then go get gas. So these are little sidebars that you want to incorporate as you're going through this activity to help your loved one with their executive function and to kind of see what needs to be done. Now, if you're working with someone and this may be a bit overwhelming, then you break your day down. So you may just include 2 or 3 things to do and only provide certain slots of time. So there are ways to adjust this type of activity to help with working on your executive functioning skills. There's also activities that you can utilize where you write them out yourself. Sometimes I wish with these that clinicians would first ask, what task can you handle then? Yes, and hopefully as a clinician that they know what is too much for you. So we're hoping that a clinician would know what's too much and that they would adjust it accordingly and also provide the right amount of cueing and prompting that's needed. So that's when you advocating for yourself comes in, or a family member advocating for you. This is a little bit confusing for me or a little bit too much. Can we break this down? So that's when advocacy comes in to play with that. All right. So I wanted to review the handouts if possible, Lauren, and talk about ways you can utilize those and talk about, open the floor for any questions, comments, and
Did you want me to put them on the screen and you wanted to talk about them?
Sure, if that's possible.
Okay.
Yes. There are some handouts that are included, and just kind of wanted to go over them and make sure there were no questions. If you can, I think they were the memory strategies, and hopefully there'll be something that'll be utilized.
Yeah,
You can pull them up.
with the
It doesn't matter.
start with the word finding?
That's fine. So what this is are some strategies that we do often, but can help the caregiver and the professional when you're showing a skill. So one of the things you can, and you actually mentioned these and you can share these with your clients. There are ways that can help you when you can't think of the word, and there is circumlocution when you're talking around the word or you're describing it. And I like to use the example of, oh, it's round and it's on a car, and it helps you decide if you're going right or you're going to go left. Hopefully it's a steering wheel. So those are the kinds of things you use when you can't think of the word, just kind of describe it. Associate it with someone. It's not a car, but hopefully a truck, or like the example says, not a dog, but a cat. Synonym, something that's similar to it, a vehicle. Gestures, I was doing that automatically, driving, show you how you drive. You can draw it. A lot of times that is easier for a person, and you can delay it. And this has happened with most of us. You can't think of it right now. You give yourself some time and it comes back to you. So these are strategies that you can actually mention and teach to a person who has a brain injury that they can utilize when they're having a hard time finding the word. I think the other one was RAP. There's some memory strategies that you can help a person to utilize if they're having trouble remembering. And each of the letters, acronyms, stand for something. And we can pull that one up, Lauren. Yep, you write it down. I call it RAP, stands for write, repeat, associate, and picture. And these are strategies that you can teach, and hopefully as a person who is having some challenges with memory, you can utilize this, write it down. I always keep a little sticky pad or a little sticky note with me. Repeat it. We do that often, especially if we're trying to remember a phone number, 248-7646, 248-7646. We repeat it. That'll help us. We associate it with something. If it's a new word, something new, something old, a name, and we picture it. And that's something that you can do quickly. I like to do this sometimes if I'm going to the grocery store. I kind of picture, I want to get lettuce and tomato, then I'll picture a salad. So I want to get the fixings for a salad. So that's a great way to remember or to utilize those strategies for memory. Okay. I think that's it. And I left you with what I need the most. And this is something at professionals and caregivers that is important for us always to remember that the person who has the brain injury, what they need from us, and not to get so busy with the remediation or the helping process that we forget what's most important for the person who has had the brain injury, and how we can be the best help for them. So those are just some tips to kind of help you meditate and think on. And hopefully this has been helpful. Are there any questions, comments?
Excellent. Thank you so much. I really
Mhm.
appreciate it. Yes, if you have any questions or comments at this time, feel free to put them in the chat or the question and answer section. I know I have a few questions as well. I really appreciated the different cultural components that
Mhm.
you mentioned and focused on. Do we see a difference in outcomes when it comes to different cultures, or, is there, where can we kind of take that information? What are we learning from the research? Do you know?
Yeah, one of the things that you want to do is that representation matters. I don't know if you've heard that term before. And one thing that I have found is that it helps to open the lines of communication with your diverse clientele when they recognize that, oh, you're respecting my culture, you're doing the best you can to understand our boundaries, and it helps with a more honest and a more productive relationship, and the relationship as a result will help with better outcomes, because then your clients are more open. They see you not just as someone who's trying to check off boxes, but as someone that's concerned about their care and their health, and that always is beneficial when you're talking about working in making things better. So yeah, that's basically what the cultural competence is showing, the research shows. Mhm.
Yeah, I think that's really excellent. I think some people might get really caught up in, like you said, putting the boxes, or like, this is how it's supposed to be.
Right.
But are there any recommendations you can have for making sure that people understand, like, if maybe they're blurring the lines between their own culture and maybe like projecting it onto another person's culture?
The biggest thing I can say is to be aware And when you see that you have made these areas, to make sure that you've acknowledged that with the person. One of the things that have found really fascinating as I've read more and more about that is often as rehab specialists, we're so focused on we've got to improve this, it's got to be better, we've got to make you independent. And a lot of cultures, it's not necessary, and that sounds so horrible, but it's true. It's not necessary that the person becomes as independent as we like, because the culture supports that person right where they are. They see that as being unique and see that as being beneficial in who they are, and they'll support that person. So even in your desire, your quest to make things better, it's important to respect that maybe in this culture, it's okay if they're not at the point where we want them, because we see that goal is, well, we can get you at 95%. And maybe as a culture, it's okay if he's at 80, because we'll support that because of what our cultural beliefs are. And we're believing in supporting each other as a collective.
Yeah, I think we see that a lot too with people that maybe, oh, like you think, oh, well, the goal is to live independently, but in some cultures,
Right.
they're not, that's not how it goes. So I think it's that you see that then there too.
Mhm.
Um, Another question, you had mentioned, starting the aphasia group, how important groups are. I know I've seen the research when it comes to, weekly kind of aphasia groups, how much progress happens when you're actually with other people using the skills really practically. What do you think was the biggest challenge with starting the aphasia group, and how were you able to kind of either overcome it, or what kind of suggestions can you give to other people that are maybe just looking to start one of those groups?
One of the biggest things that we didn't have to deal with was insurance, because we were a pro bono kind of clinic, so we kind of didn't have to deal with that per se. So that was one of the benefits, is that it wasn't income driven. So we didn't have to do a lot of, if I could say, jumping through hoops for that. So the creation of the program mainly was to provide opportunities for our graduate students, and it just kind of morphed into this wonderful, opportunity. So that was one of the things that we didn't have to deal with. And the buy-in was, we saw the results of that. So once we had done it and family members could see it and the clients could see it, then it was, oh, this is really beneficial. This is really a good way to approach it. And one of the things that really still kind of just mesmerizes me is that the individual relationships that were created and nurtured amongst that. So they would visit and do things outside of our groups. They would go to concerts together, and they would make sure that somebody had a ride to go to that museum they were going to go to, or they were all going to go out for dinner, and they would make sure you got a ride, or that who was driving or who had the transportation would get the other person there. And so just that in itself, I said, caused a sense of community. One of the things that all of us as providers and family members know is that disabilities really isolate you. And if you can do anything to provide a little bit more sense of normity and a little bit more sense of community, then you've achieved greatly. And then the communication doesn't matter, because I'm still with, if I can say, my people, the folks that really matter to me. And I think that was, of course, the biggest takeaway um, for just creating this group and groups that I've seen over time. Mhm.
Yeah, I think one thing that I see a lot with individuals that maybe struggle with communication is that idea of self-concept and sort
Mhm.
of just how they view themselves, especially in the instance of brain injury. They might have lived full lives, before their injury, and now it looks differently. It could be
Yes.
full, but it looks differently. How do you kind of manage those kind of concerns when someone is just kind of starting out on their um, communication journey and rehabilitation?
I emphasize the support of a counselor and a support group, because it's a new normal and it's difficult to maneuver that, but I really think that's a very strong component of it. I also like to pair folks with each other, folks who've kind of overcome or maneuvered the the journey, if I could say that. They may not necessarily be back at 100%. They may not have been able to return to work at 100%, but their life has evolved into something that's manageable and enjoyable. And I like to show them that person. You know, we're here, but you can still have a fulfilling life if we do all we can with what the things that we know, and we pair it with your desires, and we can kind of work together. So I pull on my community of professionals and my community of survivors to help that person get through their new journey, their new course. Mhm.
Yeah, I think that peer support is definitely really, really key. There's only so many times, someone's meeting with a professional telling them what to do. It feels like it feels like they're being scolded or like lectured to. I think that's really important to have that kind of
Yep,
partnership.
yep.
It makes me think of another thing that I've heard some in some of support groups and things like that, where some people, some of those peers may be not as patient with individuals that are maybe at a different level. Maybe that perseveration is happening. Maybe they're telling the same story. Maybe they're saying, focusing on something, really intensely. What recommendations would you have, like maybe in those group settings, and how you can kind of create that atmosphere of everybody's working towards something, and how do we work towards that patience for people that are at different levels?
And besides trying to match the most appropriate levels, we spend time reminding folks this is a safe space, and we're all moving toward a goal of better communication, being empowered, having a social outlet. So remember that you know how it feels when you've had those moments, or even where you are now. So we always start with a reminder, especially when it's needed, that we're all at different levels, and we're trying to get to an end game of working together. For the most part, as I think back, most of my group members have always been very sympathetic to each other. And I think it's because they remember and they know. And so even though there may be a sense of frustration, it's still that sense of compassion, because I've been there, or I'm still there with something that I'm still having a challenge with. So I've found, for the most part, even in the hospital settings and in the university settings, that the clients have been very kind to each other for the most part when they're struggling with those areas. Yeah.
Yeah, I definitely think that's the majority is definitely, the kindness. I think sometimes again, I think it's more just impatience
Hmm.
than, just the kind of like wanting to move forward, and that can be tough for anybody. Uh, you mentioned executive functioning, which is such a
Huge.
huge term and such a huge cluster of skills and everything. When you're working with someone, is there like a base cognitive skill that you're looking to address, like first off, just to make sure that you're building on top of a solid foundation?
Well, before we get to that executive functioning piece, we're looking at a lot of other language components. Maybe as simple as, where's the reading level? Can you even read the thing we're working on? So there's certain language components that I like to make sure are in place before we're moving to a higher level executive function. The activity that I showed is really, really high level. And there would be steps that we would take to get to that level. So yes, there are, and definitely the language component needs to be fully intact, and that would include, the reading comprehension piece, the writing, because we're doing writing with that, and even if it's not at that level where they can write, can they express themselves in such a way that someone could dictate it, or can they type it? So there are skills that should be achieved before we get to that maximum um, activity that I showed. So they are, and that's just a progression of it. And then there may be folks that don't get to that full breakdown, that full thing at once, but just do it in, smaller levels, and you break it down. So there are, I guess, prerequisites to getting to that. Yeah.
Yeah,
That's
and that
right.
brings me to another kind of really high level cognitive skill, which is self-awareness. And so
Mhm.
sometimes that could impact a lot of, I think, mainly like the social skills aspect of communication and brain injury. Can you talk about how to address like people that maybe have limited or like lesser self-awareness that maybe have, in social skills, they're either taking over the conversation or really, interrupting people or only speak like not like making it a two-way street. And again, this happens with people without brain injury and brain injury. So I don't want to single people out.
Mhm.
But is there any sort of particularly like ways that you, as a speech and communication, address self-awareness?
One of the things that happens is when you put your persons in those settings, it's so many other cues that you don't have to do as much because they're hopefully, fingers crossed, getting the cues from their peers that, okay, I'm talking a whole lot, or they're looking at me funny. And those are the kinds of things that you depend on. And then often I've had to actually stop and say, okay, let's take a moment and make sure that we're allowing everyone to talk. I can do general, or if it seems to get out of hand, then we go back and do the specific. Because again, although we have these groups, we are attacking goals, attaching goals to it. And we're trying to get to a good communication ability. So it is my job to make it sure that you're understanding the cues and you're understanding what's happening. And one thing that I like to do often in the group, we were also able to do individual sessions. So then that's also where I can address that. You remember we were in group and everyone was talking and you kept interrupting, then that's when you can play your tapes back, or you can bring that to the individual's attention in a different type of setting, and then I guess put them back in the group, if I can use that terminology for that. So sometimes the individual one-on-one sessions help to cultivate those better awareness skills that they may be missing the cues in a group setting.
Excellent. Yeah. And Stephanie mentioned in the chat that, when we were talking about peer partnerships and things like
Mhm.
that, that also might be an opportunity for, that self-awareness coming from a
Right.
peer as well. She had mentioned, even, pairing opposites might be beneficial, not even just, that can be really helpful
Yes.
um, to help people as they're on their journey to learn about other people's experiences.
Mhm.
Um, and things like that. Thank you so much, Stephanie, for that. I appreciate it. Another question that I have, you'd mentioned, singing, and I know before we got on this, we were talking a little bit about music and that
Mhm.
impact on speech. Can you talk a little bit about, what that looks like in terms of treatment, a treatment plan, or incorporating either music or singing or anything? Can you talk a little bit more about that?
That's something that's not as readily available in a lot of our rehabilitation hospitals now. So it's something that you might have to seek out. One thing that we used to do at one of my facilities is we had a volunteer that played the guitar, and we would just schedule her to come, and we would have sessions, together, kind of what's a good word? Kind of, I don't want to use the word haphazard because we planned them, but kind of spontaneous. Well, they would come, and we knew they were, she was going to come on a Thursday at 2. So we would make sure our folks would be available at that time who were in the rehabilitation hospital. And we provided singing, books with the large print, and she would just kind of say the name of the song, and we would go from there. So that was one way we kind of got around the formal music therapy that was really helpful. There are other community groups that have welcomed folks. When I was part of the Parkinson's Project, they had a Parkinson's choir, so they would come together and practice, and that was part of their community kind of thing. So I think you have to kind of create an environment that isn't already there for your folks, which is it may be as simple as a volunteer. It may be as easy as putting, the music on at home and joining in simple songs, or just start singing, those songs, take me out to the ball game, happy birthday, and just including your loved one in those kind of sing along spontaneously to include those. So I think music and singing is something that you can almost do anywhere, anytime, and kind of create that environment, even if it's not something that's quote formal at a building or that. So I think it's a lot of ways to incorporate that. That's easy to kind of do. Mhm.
Yeah, I think that brings up an important part of like, making sure that your rehabilitation is kind of everywhere, right? It's
Mhm.
not just in one, building with your speech pathologist or, whoever your therapist is, but kind of translating it to the home.
Right.
Are there any other strategies you have for, making sure that that information is translated to all different areas of a person's life?
Making sure that your family and caregivers, and it's hard because if you're always caring for someone, know that there's so many different ways that you can incorporate your communication. Like we said, the singing part, simple things in terms of how you're going to schedule your activities. Can you help me do that? Using your physical calendar. We have gotten so electronic now that a lot of the strategies I've used over the years have kind of disappeared. We don't have calendars in our home anymore, but it was a great way to utilize the strategies. Okay, can you check what we have to do on Tuesday, or whatever method you're using to keep track of scheduling, that you make your loved one part of the planning process. Okay, so we're going to go to the grocery store. What are some things you'd like for dinner? So then, even incorporating them, writing that down, or making that list, or thinking about, okay, let's think of a meal we want to prep and what items would we need to buy. And they may not be able to say all of them, but it may be as simple as, oh, we need this, and to help them where they are, to include them in even everyday kind of tasks. Can you get the clothes out of the dryer for me? If you're working on mobility issues, and then having them fold and sort, things that seem kind of simple, but including them in everyday activities and providing that communication component, that organization component, helps also help the caregiver to recognize they are. Yeah. What was that about the caregiver?
Yeah. So Stephanie had mentioned, that these type of strategies and even adding music to the home, and I was even thinking, that empowerment process that you were talking about, kind of like, oh, like, what do you want for dinner, and giving people the opportunity for choice. All of that is hopefully to, give the caregiver kind of less stress. You're kind of giving the tools to the individual living with a brain injury so that they can kind of future do it on their own, or
Hmm.
move towards that. So I think
Hmm.
it might feel like a lot at the time, because you're like sort of having to like uh, give a ramp to the individual to do it, but the end goal is hopefully really powerful and positive for everybody. Um,
Yeah.
so, and I think that's definitely a key component, because, like you said, the caregivers are already so overwhelmed a lot of times, and they're managing a lot, as is individuals with brain injury.
Hmm.
Rehabilitation is not an easy process. It's really stressful and tiring.
Right.
So, the more that as clinicians, we can all help with reducing stress, giving tools, and empowering people, whether that's whoever we meet, I think that can be
Hmm.
really important.
I agree.
You had mentioned specifically the use of electronics and technology. What have you seen as most useful for individuals living with brain injury in terms of communication? Have you worked with a lot with, like, either augmented speech or communication boards, or where do you see the role of technology moving us forward?
I have not worked a lot with AAC devices, but I have worked with reminder things. So I find that it's even personally, so even professionally, having the reminders on the phone, because even being able to function and use those to me is a whole cognitive concept in itself. But having those brief reminders, the things that we use every day are very beneficial for persons that have brain injury. So I see all of those things, all those things we have on our phone, the scheduling that we're able to do on the phone, the reminders that it provides. And I think those are very, very beneficial. For the most part, folks have, access to computers, and that also allows for a different type of communication where before we didn't have it. So if you have someone who's struggling with the verbal expression, but the reading and the writing are intact, then they're completely able to utilize that to communicate with folks, the text messaging. So those types of things are some of the simple things that I have seen more use of and more useful for persons who've had brain injuries. Like I said, I don't have as much experience with AAC devices, but I see the benefits of those, and they've become smaller. They used to be really big, but now they're small and can be utilized for lots of different things, and that's really been really, really grateful for, like I said, persons who have the receptive languages intact. They just can't get it out, and they're able to utilize iPads and phones to communicate, and that's always beneficial.
Yeah, absolutely. I was actually talking with a family recently, and I'm curious your response to this because I know how I feel about it.
Mhm.
But I think either insurance or someone, the funder would not pay for an iPad because there were other apps on it, even though that was their main form of communication and speech.
Mhm.
What kind of response do you have when a lot of times if funders are looking for any opportunity to say no when communication is just as important as physical health?
And that's to me when you then say, well, this is the person's primary form of communication, and I think it's the way that you can write that to say it may have other apps on there, but this is what we're using it for. Or if we need to remove those apps so that they can use it for that, then fine. Then that's also a way to support their need. But it's important to let folks know that although there are lots of things that we use in our life that has twofold. A car, we needed transportation to get us to doctor's appointments, but it also takes us to sporting events and social occasions. And so I shouldn't have transportation to go to the doctor's because it also can be used for other things. So there are ways to kind of make people think in terms of what they're saying about something that's useful. But like you said, it's just a way to try to not pay for something that the person's entitled to, I believe. Mhm.
Yeah, it's definitely one of the most frustrating and
Very
we've
frustrating.
got some people in the chat also, very frustrated by, the insurance and
Yes.
how it won't cover specific technologies. But luckily there are different types of, AI, artificial kind of
Hmm.
intelligence these days that do help with
Yes.
speech recognition technology and even, smartphones that have disability accessibility
Yep.
components. And I think that's something that we can at least relish in, and that is often um, more accessible to people in the palm of their hand, and
Yes.
something that maybe they could do at work too. So, and not necessarily like if they request an accommodation, but it's not as like visually
Hmm.
overt. Um, and then so we're gonna finish up here soon. Um, but I did want to say, so someone in the chat mentioned, if it's specifically traumatic brain injury waiver, as we do
Do
have
that.
here in Medicaid, North
Yep.
Carolina, justification just needs to be there, and it would need to be presented as a communication only iPad, speech language pathology recommendation, and doctor recommendation.
Yep. I was thinking
So
that you could do that, get around it, do that. Yeah.
mhm. Yeah, I think the key is all creativity, justification, and try and work with what you got. But it's frustrating that that is still being such a difficult
Difficult. Yes.
barrier. Um, There was a question about what counties in North Carolina are allowing the traumatic brain injury waiver. And so the waiver is still in the Alliance catchment area. It is in Johnston, Wake, Cumberland, and Durham counties, and it is looking to now expand to Orange and Mecklenburg counties. I'm not sure the specific date on that rollout, but I encourage you to take a look at, I'll put Alliance's website in the chat, so that you can learn more about that. As she mentioned, Mecklenburg, it has been previously excluded, but I know that they're currently looking for providers to expand in that way, as Alliance took over the Cardinal Innovation Solutions LME MCO. So my last question that I wanted to pose to you was, what gaps still exist in the kind of whole spectrum of communication and brain injury, and what can we do to make changes to creating solutions for those gaps? Is it more, tools? Is it more access to, free materials? What do you see in terms of, what solutions we can create?
I think it's all of the above, the things that you said, because I think in every area you can see where there needs to be a little more help in this, a little more help in that. One, I think of the strongest components is the collaboration piece, as not only allied health professionals, but as allied health professionals, family members, advocates, all of those kind of working more collaboratively and interprofessionally to get some of those things done. I think we have a larger, louder voice, and reminding ourselves as professionals that we don't work in bubbles, that we really are kind of working together, because our benefit is to get our patients, our clients, to the maximum level of achievement that we can using the resources that are available to us. So I think that a more collaborative approach to things would be beneficial to us, and not only from a professional standpoint, but also working more with family organization and community organizations, kind of a group effort. And as we see the gaps, working toward mending those gaps. And the one way is understanding what you do and understanding what I do and how we just kind of overlap. So I think more advocacy, more collaboration interprofessionally can help us to achieve, because if you look at them, we're all going to be affected by those gaps. It's not just an isolation, it's all of us. So we want to kind of work together to do that. Let our, of course, legislators know that we're here and we have needs, and that there are things that we are supporting and we want you to support also. So I think it's a lot of effort in a lot of areas to kind of continue, not just see ourselves as being isolated. Yeah.
Excellent. Yes, I think that collaboration is essential, and it could be hard because we're all just trying to make headway in whatever way that we are, but by connecting with everybody, everyone wins.
Yes.
So thank you so much for your time, energy, your presentation. We've gotten, great feedback already.
That's good.
I'm gonna put the certificate link in the chat. You'll also get that certificate as well as the handouts and the presentation slides in your follow-up email, which will come out tomorrow, about a day from the 12 o'clock. But you also should have received them in your previous email as well. We saw some feedback of you guys wanting to have it a little bit more ahead of time. So I'm glad, hopefully that was helpful. Feel free to fill out the survey that you should be directed to in the follow-up email, or possibly when you close out of this webinar. And if you have any questions or concerns, feel free to contact the Brain Injury Association of North Carolina. I'm also going to put back Dr. Miller's contact information in the chat again as well. And other than that, thank you so much for everybody for visiting us today, and hope to see you at the next webinar for college supports and brain injury, as well as the powerful tools for caregiver in November. And other than that, thanks so much. Have a wonderful day. Thanks so much, Dr. Miller.
No problem. Thank you. And is it okay to log off?
Yep,
Okay.
I'll end it now. Thanks, guys.
Okay,
Bye.
great.